Let's talk about the appropriate patients, which brings us right now to high-risk populations, okay? I do want to save a little time at the end to talk about why do you have to be high risk if we can do better for everybody.
That's a good point.
But we're going to start out with high-risk people because back in the day of the early statin therapy, only diabetics and smokers got statins. And we've changed that. So we could foresee a day where things might change. But for now, let's talk about high-risk folks. You're starting to treat a high-risk population. What follow-up do you do early on? I mean, just mechanically in the office to ensure that you're getting a result.
Well, you would do a blood test. You do a blood test generally after about 4 cycles, so about 2 months. And you're looking at this because A, tells you if you're giving enough drug, because you do have a targeted goal. B, it also helps the patient. It motivates the patient to see how well they're doing. And if you're not doing well enough, what do you have to do to get there?
Okay, so every 4
to 8 months.
4 to 8 months.
4 to 8 weeks.
4 to 8 weeks.
Yeah.
You're going to bring them back.
Right.
You're going to check and then start to ramp up
Exactly
if necessary.
correct.
All right. Is that quick enough?
Yeah, I think that's good. I do the same thing, 4 to 8 weeks.
Okay. How did you pick 4 to 8 weeks? And where do you start? Do you start low? Do you start high? Do you start medium?
Well, I think actually, when you look at the exact recommendations, there is no absolute recommendation to bring them back to check it.
That's my point.
Exactly
There's
right.
no recommendation.
Right.
Right? I hear him laughing behind me. I know you're laughing back.
Yeah.
Because I'm playing devil's advocate here. It sounds great. It sounds like something a clinician would do. And by the way, I don't disagree. But he's going to say, where's your evidence? Aren't you?
Well, actually,
Or no?
Yeah, but wait a second. In the guidelines, in fairness, buried on page 82 or something like that, they do recommend that we follow up LDLs to be sure that drugs are working. So there is that recommendation. It's sort of hidden, unfortunately.
And go ahead.
No, I was going to say that I think most companies, again, it's hard to generalize with managed care, but I think most managed care organizations do not get that deep into the weeds in terms of asking for follow-up laboratory results. We take what we call physician attestation. If the physician tells us something that they have, I know there was an issue here about what evidence do we require for the diagnosis of FH. If the physician says they have it, we accept their word for it.
You don't need a genetic test? I've heard you do.
Well, that's my point, is there may be some organizations, some companies that do that, but I'm just speaking in general terms.
Okay.
Most of the companies that I'm familiar with do not get into that much detail.
And allow me to ask you, does it matter? Does it matter? If the LDL cholesterol is 250, does it matter how it got there? Does it matter if you were genetically predisposed because you have FH or because you were eating a cow a day? Does it matter? Why would an insurance company?
It does matter.
Why?
It does matter.
Why?
Because FH patients in utero have very high LDL.
Okay.
So they have a lifetime elevation.
That's not my point. My point is somebody comes to you with this LDL.
No, but that increases their overall risk for heart.
Fine.
Right.
But you're going to do the same thing. You're going to get their LDL cholesterol down. Why would an insurance company want genetic information if what you're going to do is the same thing?
Genetics, that's an entirely
That's my
different
point.
story.
Right.
Yeah.
No?
But there can be, and I'm sorry it always is me here, there are several different criteria to diagnose FH along with genetics. One of them is the Simon-Broom criteria, which involve knowing whether one of your first-degree relatives has bumps on their Achilles tendon. Now, I know as a child, I never inquired whether my father had bumps on his Achilles or elbow tendon, but they asked those questions. Are there extra cardiac stigmata of hypercholesterolemia? And if you don't know this, I have been refused by companies, not yours. I've never dealt with your company or yours, but they do deny saying because they cite that criteria. And it's a moving target.